Welcome to Grand Rounds for March 2026. Today we have Dr. Stephen Clemson talking to us about acute low back pain. Dr. Clemson graduated from Misericordia University with a bachelor's degree in healthcare management and then earned a doctor of physical therapy degree also from Misericordia University. He then completed his orthopedic physical therapy residency training at Arcadia University's orthopedic residency and subsequently earned board certification in orthopedic physical therapy. Currently, he's completing his spine fellowship training at St. Luke's University Health Network. Dr. Clemson practices orthopedic physical therapy at St. Luke's University Health Network's Hazleton office, where he is the facility director. Throughout his time in the Hazleton area, Dr. Clemson has developed a particular clinical interest in the management of spinal conditions. As a housekeeping reminder, make sure that you scan in and log into EADS within the 24-hour time period from now until tomorrow if you're doing the live version. And make sure that at the end of the presentation you complete the quiz and the course evaluation so that you can get the appropriate CME or CE credit. And if you're watching the recorded version of this, you're already in, so excellent. This is our statement of need, and the target audience is all providers. This is our designation statement, and the planners and presenters have nothing to disclose. So without further ado, I will turn it over to Dr. Clemson.
Thank you for that introduction, Dr. Karaha, and thank you all for joining today. Before I begin, I would like to thank Dr. Karaha and the rest of the Spine Fellowship staff here at St. Luke's for all of the support and guidance as I make my way through this program. Today, we will be covering a practical, clinically relevant approach to acute low back pain. This is one of the most common and costly problems in healthcare. So as you see here with the learning objectives, this is where we will be going today. These objectives reflect problems we see every day. Over-imaging, over-prescribing, under-educating patients. My goal is that you leave with better clarity on when to act urgently and when reassurance and conservative care are the best course of action. Before I continue, I'd like to share a personal story as to what sparked my interest on this topic. During the spring of 2019, I was visiting my parents, and upon speaking with my dad, he disclosed an acute left-sided low back pain that he's been experiencing for a couple weeks now. He thought nothing of it, and me being his son in the field of physical therapy, I suggested we do a quick assessment to see if there was something I can help him with. As most of you probably don't know, my dad was a physical education teacher for 30 plus years and a very avid outdoorsman. He exercised 4 to 5 times a week and was very active. He usually would have something that was, let's say, sore on him from being active, but he wouldn't really fuss much about it, and it would go away in a few days to a couple weeks. We ended up agreeing on a few stretches to try to add into his workouts to see if this would help him. So despite being very close geographically with my parents and practically speaking to them over the phone most days, I never followed up on this in a timely manner. I started a residency program in August of that year and got busy, and he just tried pushing this off as a normal ache that he was experiencing. That was until he went on a trip with a few of his friends and started noticing some urinary urgencies and decreased abilities to void. He decided to follow up with his PCP. So fast forward to November. He received news that he had stage 4 prostate cancer that had metastasized to his pelvis, spine, and his ribs. Before I go any further, I'd like to say that my dad is celebrating his 67th birthday today, thanks to his primary care physician within St. Luke's, Dr. Craig Krause, and the brilliant minds down at Penn State Hershey Medical Center who spearheaded his treatment efforts. But the point of me telling this story plays heavily on some of the information I'm about to cover in this presentation. Listening to your patients and asking specific questions, such as the one that I failed to ask. Is your sleep disturbed? And if so, are you able to get back to sleep? And taking an appropriate history along with ensuring there's follow-up care in a timely manner to assess if conservative measures are making meaningful changes, and if not, when to send that patient on for further evaluation. So let's take a look at low back pain. It affects over 600 million people worldwide and is expected to rise significantly by 2050. This is driven largely by population expansion and aging. It is the leading cause of disability globally. Low back pain can be experienced at any age, and most people will experience low back pain at some point in their lifetime. Prevalence of low back pain increases with age up to 80 years, with the highest number of low back pain cases occurring between the ages of 50 and 55. Low back pain is more prevalent in women than men, and most cases are nonspecific. Actually, 90% of these cases will not have a serious pathology. Most pain is nonspecific again, and serious pathology is rare. But identifying that rare case is why we're here. So if most improve, what does the natural course really look like? Prognosis of an acute low back pain is overwhelmingly positive, and in most cases, it will resolve on its own. In fact, most people have a substantial improvement within 4 to 6 weeks, no matter the treatment choice. The danger comes when non-evidence-based practice leads to chronicity. This includes unnecessary imaging, rest instead of activity, and over-medicalizing normal pain. Psychosocial factors are often strong predictors of chronicity, and they weigh higher than physical findings themselves. Chronicity is costly for systems and patients. So as you can see here, low back pain is the third highest cost per capita chronic disease in the United States. This only sits behind hypertension and diabetes. This is not just clinical, it's a workplace, insurance, and systems issue. Much of the cost that you see here is tied to imaging procedures and chronic disability. This leads to a problem of over-medicalization. So let's first identify the difference between nociception and pain. Nociception refers to the neurophysiological process by which specialized primary afferent neurons called nociceptors that detect actual or potentially harmful mechanical, thermal, or chemical stimuli. These signals are transmitted via the peripheral nerves to the dorsal horn of the spinal cord, where they undergo modulation before being relayed to supraspinal structures or spinal motor circuits. Nociception can activate rapid, reflexive protective responses, such as the withdrawal reflex, all without necessarily generating the conscious experience of pain. As a protective detection system, nociception plays a critical role in maintaining tissue integrity, yet it is not synonymous with pain. So what is pain? Pain, in contrast, is a subjective conscious perception that emerges when the brain interprets nociceptive input, or sometimes the absence of such input, in a way that is experienced as unpleasant or threatening. Pain perception is shaped by multiple dimensions, including sensory, discriminative, cognitive, emotional, and contextual factors. As defined by the International Association for the Study of Pain, pain is, and I quote, an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. This definition reinforces that pain is not solely a measure of tissue status, but rather is a complex output of the nervous system influenced by biological, psychosocial, and social processes. So simply put, nociception is detection, whereas pain is perception. So Over-medicalization. There's a high likelihood that patients experiencing an acute low back pain episode will have unnecessary treatment and diagnostics provided or ordered for them when seeing a primary contact in the medical field when evidence-based approaches are not followed. It is our job to ensure that we are applying the current evidence to guide our selection of these interventions and tests. Imaging is a prime example. So let's look at the guidelines. Imaging is a tool, not reassurance. The reassurance for the patient comes from each one of you. Routine imaging may cause more harm than good for patients with low back pain, not demonstrating clinical red flags. Early imaging is shown to not improve clinical outcomes and may lead to unnecessary labeling and downstream procedures. This also leads to increased costs through imaging, injections, and even surgeries. So how can you handle this when a patient is insisting on receiving imaging of their newly acquired low back pain? Things you would do when speaking with a patient include validation, or telling them you hear their concern, but then educating them on what is important and why their symptoms may not be relevant for additional imaging or procedures. Reassure them that the symptoms that you are finding during your examination are safe for activity, and letting them focus on their abilities to get back to their desired activities. Also letting them know that we are going to continue to monitor for any change in their symptoms, and if, say, X and Y occur, that we can escalate this promptly and get them in for proper evaluation. Part of counseling the patient also includes discussing potential costs. So as you can see here in this table, through my research, I found some average costs of specific procedures that may be associated with an initial visit for acute low back pain. If someone is being referred for unnecessary imaging, including a lumbar X-ray and even an MRI, they can incur costs over $2,000 more than just their visit that may be adequate in treating what they have going on. So, if imaging doesn't guide most cases, what should? Let's dive into red flag identification. So what is a red flag? The term red flags was initially introduced in the 1980s and originally was intended for low back pain. It was first used by the Clinical Standards Advisory Group in 1994 to indicate serious medical conditions that may present as common or non-serious musculoskeletal issues. Red flags serve as warning signs that raise suspicion of underlying serious pathology and are used to guide further diagnostic testing. Red flags are essential, but an individual red flag tends to have low diagnostic value. Combinations matter, as they tend to substantially increase specificity and positive predictive values. The goal here is to identify the rare but serious pathology, such as malignancy, vertebral fractures, infection. Taking a thorough history and physical examination are still our most powerful tools and are essential for triage and identification of potential red flags. So we talked about these clusters. Let's start with malignancy. This is the spread of cancer throughout the body, and the most important factor here to identify is a patient's history of cancer, as this increases the likelihood dramatically when paired with clinical suspicion. Again, the cluster of symptoms here, if a patient is presenting with them, this would warrant further evaluation, and it is not a diagnosis, but a need for further assessment, whether that is through imaging or additional testing. Next, vertebral fractures. This is something we should watch for in the older population. Also, somebody who's had significant trauma. If they've been on prolonged dosages of steroids, or they have a history of osteoporosis. In the elderly, trauma, even low energy, can be clinically meaningful. Fracture likelihood increases substantially when multiple signs are present. And in fact, being over the age of 50 increases that likelihood ratio up to a 2.2, and over the age of 75, the positive likelihood ratio increases to 3.7. These signs and symptoms, when paired together, should raise a flag and warrant additional screening. Infection. While fever is key here, it may not always be present. So doing a thorough history is important. Asking the patient if they've had any recent procedures or have had any systemic infections, if they're experiencing any feelings of fatigue, malaise, and swelling in parts of their body, if they have a history of any IV drug use or a history of indwelling catheters, this significantly raises suspicion that there may be signs of infection. In fact, IV drug use carries a positive likelihood ratio of 14, and a history of indwelling vascular catheter increases that likelihood ratio to 16. These patients need urgent evaluation. Most likely, they will be sent for labs and some additional imaging, such as an MRI. Now, Cauda-Equina syndrome. Strongest predictor here is urinary retention, which carries a positive likelihood ratio of 18. Additional symptoms such as saddle anesthesia and progressive bilateral neurological deficits go along with this diagnosis. This is an emergency, and it requires immediate medical referral. This is not something that we would wait for an outpatient imaging to diagnose. This is something that is getting sent to the emergency department for immediate evaluation. AAA, or an abdominal aortic aneurysm. These patients may or may not present with a pulsatile mass in the abdomen, but maybe it's not there. So what else do we look for? If they have a history of any type of vascular diseases or coronary artery disease, it's important not to miss this, especially in the older patients with vascular disease. Pain with AAA can refer to the back, the abdomen, and the groin. And again, if there is suspicion for this, the patient should be referred for further evaluation. We are not diagnosing them with this. We are following up with additional evaluation. Lastly, inflammatory disorders. Here we're thinking something along the lines of ankylosing spondylitis. Symptoms such as morning stiffness lasting greater than 30 minutes. If these symptoms are improved with exercise and not at rest, night pain in the second half of the night, alternating buttock pain, family history of it. Let me be very clear. Red flags guide escalation, not diagnosis. So again, this is why each of these are warranting further evaluation and some type of imaging. So now that we understand the red flag categories, let's apply them. So just a short case here. We have a 52-year-old male with new onset of low back pain. Pain's been present for approximately 3 months. And he's noticed a 10-pound weight loss. He's had night pain. He has a prior history of prostate cancer. On exam, physical findings are not mechanical pain. And he's got some focal tenderness over the L3 vertebrae. His neurological exam is within normal limits. Here we should be suspicious of metastatic disease. And this would warrant us referring that patient for additional imaging, possibly including labs, and coordination with either the primary care physician, if they have one, or potentially oncology pending the results of any imaging. So case 2, the 38-year-old female with acute low back pain. She's running a temperature of 101.5, She had a recent dental abscess. She's reporting fatigue. On exam, she has paraspinal tenderness. She's got mild tachycardia and no neurological deficits. So what should we be thinking here? Possibility of infection, spinal infection. Again, this requires urgent referral for further evaluation. Even if she was not presenting with a fever, as that is not always present in these cases, the other signs, the history of the dental abscess, this increased heart rate, these are all things that may warrant further evaluation. So we talked about red flags, but what about the other 4 flags? In most cases, these other flags are non-emergent, with the exception of orange flags. It's important to be aware of these, to address this in a timely manner, and decrease the risk of an acute episode developing into a chronic situation. So what are these? Orange flags refer to serious mental conditions that may require urgent evaluation or referral to a behavioral health specialist. They function as the psychological equivalent of a red flag. Signaling that a patient's presentation may not be appropriate for standard musculoskeletal rehabilitation pathways under their mental health needs, this needs to be addressed by a professional. Common orange flags include severe or clinical depression, major personality disorders, PTSD. So when orange flags are present, clinicians should prioritize referral to mental health professionals for a comprehensive assessment and management, as our typical musculoskeletal or pain-focused interventions may be insufficient or inappropriate for this patient. Yellow flags. This involves the beliefs, emotions, and behavioral responses that influence how a person interprets and manages their symptoms. These factors strongly shape the risk of transition from acute to persistent pain. Examples include catastrophic thinking or fear avoidance beliefs, low self-efficacy or pessimistic expectations about recovery, maladaptive coping strategies. These factors guide clinicians in tailoring patient education, reassurance, and behavioral interventions. Blue flags. This relates to the patient's views about their work environment. This includes how job demands or workplace expectations interact with their health condition. And examples could be something similar to a belief that work is unsafe or harmful, or a perception of low workplace support. This is something that needs to be addressed so that it does not turn into a chronic condition. Black flags. These arise from external factors, such as organizational, legal, financial, or social factors. This limits a person's ability to recover or participate fully in rehabilitation. Examples include restrictive workplace policies, compensation or insurance system constraints. Again, this is something that we may not have full control of, but we should do our best to help facilitate an easier process for the patient by working with an interdisciplinary approach. So a study I found was performed in 2024, identified 22 relevant clinical practice guidelines worldwide, not just in the United States, but throughout the world, and it compared treatments for acute, subacute, and chronic low back pain. Now, the results were fairly similar for acute low back pain and subacute low back pain. And the guidelines recommended the use of nonsteroidal anti-inflammatory drugs, therapeutic exercise, staying active, spinal manipulation. Again, across global clinical practice guidelines, these 4 recommendations are holding true for an acute and subacute presentation of low back pain. This leads us into conservative management. Conservative management is essential for this patient. Education, keeping this patient informed that they have a positive outcome, letting them know that activity, not rest, is key. They need to stay moving. Initial non-pharmacological care is the foundation. And PT as an early intervention, or physical therapy as an early intervention, will help improve outcomes. Collaboration across disciplines ensures continuity and prevents chronicity in these acute low back pain cases. A consistent message by all healthcare professionals reduces fear and improves outcomes. So making sure that we are all on the same page is essential for this patient population. This image here highlights the conservative management options for a patient with acute low back pain that we will discuss in further depth. So what are some non-pharmacological interventions? I mentioned physical therapy. In addition to that, superficial heat, massage, spinal manipulation, acupuncture, advice to remain active. These all provide some improvements to that patient when they are meaningful to the patient and they help address the symptoms that they are currently experiencing. Again, activity remains one of the most important parts of this rehabilitation process, and addressing that with the patient to ensure they are educated on a safe return to activity is essential. What are some of the first-line pharmacological interventions? NSAIDs, or non-steroidal anti-inflammatory drugs. They offer a small but meaningful improvement in pain and function. In addition, skeletal muscle relaxants offer a modest short-term relief. There's not really a lot of evidence for any functional improvements. Now, one thing that we need to be careful when selecting any medications for these patients are comorbidities. As any GI or renal problems, or if there's concerns for sedation, especially in the elderly population, this all needs to be considered prior to prescribing these medications to this patient population. Always personalize this to the patient risk factors and what their preferences are. So, good care requires integration. Multiple disciplines across the healthcare companies are required to address this, as it's seen in all of these roles every day. We want consistency with our messages across these disciplines to help avoid mixed signals for the patient. So let's dive into these roles a little further. Physicians, while most of the time they are going to be the primary triage, it's important that this professional gets the history right. We are making sure that we are asking appropriate red flag questions, and we are determining the next steps, whether that is referral or the advice to remain active and pursuing a conservative course of treatment. We want to make sure that we are avoiding over-ordering imaging, as it is shown to decrease success rates. We need to provide reassurance and education and set these expectations with the patients early. Physical therapists. We can reference that initial contact slide, as physical therapists are often the first point of contact, especially in a direct access setting. It's important that we are doing a thorough red flag screening and ensuring that this patient is not appropriate for a referral for additional imaging or for additional services. It's important to, again, provide that educational aspect. Prescribing exercise, providing manual therapy, and monitoring for positive improvements or changes into a more chronic state or emergence of red flags. If we are seeing this, we need to make sure that we are routing this appropriately to prevent any significant problems. So as you can see here, in the 2021 Clinical Practice Guideline update by George et al., they determined that for patients with acute low back pain, there was level 1 evidence supporting thrust and non-thrust joint mobilizations. They also suggested exercise and patient education in these cases, as mentioned previously. Physical therapy is central to early management, and early physical therapy helps reduce short-term pain and disability and helps prevent these acute instances from turning into a chronic condition. This is especially helpful in acute radicular pain, where we're seeing positive improvements to long-term outcomes. Next, nurses. So if this is something that is related to a job injury, a nurse case manager may be essential here, as they are facilitating that communication between the practitioner that the patient may be seeing, physical therapy, and the patient themselves. This specialty needs to reinforce the core message that movement is safe. Imaging is not routinely needed. This adds to costs and decreases success. Monitoring for changes or new red flag symptoms during that communication with this patient is essential, and that communication should be made to the appropriate professional. Also, nurses outside of the nurse case manager can also support for medication management and care coordination, as they are usually the primary contact point when dealing with a physician. Some other roles. However, this is not an exhaustive list of everyone that is involved in this care. But occupational therapists, if this patient is injured at work or this onset has occurred while that patient is at work, these professionals are key in helping to return that patient to their desired level of function and their prior activities at their job. Psychologists, if we are running into any of those additional flags as mentioned earlier, this is where some of that would play into the case here, and these professionals are best at handling this. Again, case managers. It is essential that we are all on the same page and make sure that we are communicating the same message to this patient that remaining active is essential. So just to reinforce that, combining physical and psychological treatment, this makes our success rates increase exponentially and is very highly effective for persistent cases. This helps reduce pain and improve function, and it supports a return to work. Collaboration within the multidisciplinary approach is key for high utilization patients. So let's look at another case. We have a 28-year-old male warehouse worker with acute onset of low back pain after lifting boxes at work. There's no red flags present upon screening. Pain is mechanical in nature, and he's not presenting with any neurological deficits. So what's our plan here? Educate the patient. Make sure that they're returning to activity as tolerated. Possibly apply modalities such as superficial heat. Are they appropriate for a short course of NSAIDs? Getting them into physical therapy. This is a case of acute, non-specific low back pain. Getting these patients back to work, whether that is their normal duties, if they're able to tolerate them, or if there are modifications necessary, is ideal for a successful outcome. So let me just be clear. Education alone is often outperforming passive treatments, and return to work is one of the most powerful predictors of recovery. So, our primary goal of return to work is to prevent a chronic disability. Staying at or returning to modified duty within days, when feasible, is ideal. We need to make sure that if we are offering restrictions, they are function-based, as these are more beneficial than blanket weight limit restrictions. Again, as mentioned earlier, there needs to be a coordination of communication between the clinician, the therapist, the employer, the case manager. Everybody being on the same page increases the likelihood of a speedy recovery in these patients. We really need to make sure that these patients are getting back to work, as this correlates with better outcomes in the long term. Educating these patients and educating not just the patients, but maybe their family members and people around them, this helps to tie everything together. So, I've talked a lot about education, but I want to stress this might be the most important aspect of this entire presentation. It's important to build rapport with this patient and validate any of their concerns, as this supports a better patient-clinician alliance. We need to make sure that we're using plain language and avoiding that biomedical over-explanation that may go over the patient's head. Ensure the patient that pain does not equal structural damage. As mentioned earlier, the difference between nociception and pain. Let them know that rest is not required for these structures to heal. We need to make sure that the patient is aware that the prognosis of this diagnosis is positive. Again, pain is not equaling damage. Backs are strong, and movement is medicine for the back. It is essential to keep the spine moving to help prevent this from turning into a chronic issue. So what are some things that we can do to further help this patient move on? Offering advice is such as weight loss or weight reduction to help reduce any reoccurrence or symptom burden. Weight increases mechanical load and also increases systemic inflammation. So if we're looking to offload these areas that were potentially harmed in the incident, decreasing that mechanical load to them allows them to heal faster. Discuss with the patient smoking cessation, as this allows for improved healing. Getting this person physically active, talking to them about their stress and their sleep patterns, as these all impact pain. Small, substantial changes support long-term spine health. So, to reiterate, what is not recommended? Bed rest prolongs symptoms and delays recovery. This is something that should be avoided. Modalities such as ultrasound and, in cases, traction have little evidence behind them. We're trying to avoid early imaging, as this is non-specific, in non-specific cases, as this is not supportive of a better outcome, and it can actually negatively impact a patient's recovery. Opioids, these should be avoided, as the risks do not outweigh the benefits in a case for acute low back pain. Now, I've broken this down into different age groups, but essentially the treatment approach is the same. For pediatrics, physical therapy and activity are highly recommended, sparing use of NSAIDs, and we're not really ordering imaging on this patient population, as this tends to resolve fairly quickly. Children are resilient. They move naturally, and they want to move. So they do better when they have an acute onset of low back pain, because it's in their nature to continue to move. Adults, geriatrics, may potentially require a little bit more education here. Encouragement to stay active. Getting them into physical therapy to guide that activity. Using guideline-based care and screening for any type of psychosocial factors is extremely important in these populations. With the geriatric population, there should be caution when prescribing medications, as mentioned previously, NSAIDs, skeletal muscle relaxers. There could be an adverse event here if there is a history of any of those issues. For geriatrics, we should essentially prioritize gentle, tailored exercise to what that patient can tolerate. Again, it is an individual basis. So let's review one more case before wrapping this up. So we have a 64-year-old with severe bilateral radicular pain, saddle numbness, urinary retention. On exam, there's progressive bilateral weakness and decreased anal sphincter tone. So what is our approach here? This requires an immediate emergency department referral. This is likely a cauda equina suspicion and needs to be evaluated promptly. Again, an emergency. This is not being sent for outpatient imaging, as this needs to be dealt with immediately. So, to bring it all together, I found this triage algorithm from the VA. There's a lot on this slide, and it continues on to the next slide. However, I think it is very appropriate and very detailed as it walks you through the course of action for a patient with acute low back pain. As you can see here on the right-hand side of the slide, it identifies those red flags. And on the next page, it continues with some of those red flags as seen here. It also has recommendations for an acute episode and then a subacute or chronic episode. We are reevaluating this patient at 4 to 6 weeks. If their pain is continuing past that, that is turning into more of that chronic or subacute phase, and that is not what this presentation is focusing on. More simply put, here is my version of this clinical triage algorithm. Taking a thorough history and examination is essential in these cases. Identifying red flags. If we are seeing a cluster of red flag symptoms, it is appropriate to refer to another healthcare professional for additional workup. If these red flags are not present, conservative care and active monitoring are the frontline medicine to these patients. Making sure that we are checking in on a routine basis, 2 weeks, 4 weeks, 6 weeks. We need to make sure that we are reassessing these patients and ensuring that we are not missing any specific red flag presentations and that we are not missing any of the other flags that could potentially lead this into a more chronic condition. So, some myths and facts, as you can see here on the slide as a recap. But let me highlight the top 10 clinically actionable points. We want to make sure that we're documenting clusters of red flags and act fast when present. We need to make sure that we're setting explicit follow-up and safety net instructions. If X and Y are occurring, we will follow up with Z. We're avoiding early imaging in non-specific cases. If it is specific based off of our red flag screening, we are sending that patient for additional imaging or additional workup. Encouraging activity and avoiding bed rest. Use of NSAIDs or a short course of spinal muscle relaxants selectively. We need to make sure we're applying these to the appropriate patient. Screening for yellow flags, blue flags, black flags, orange flags. This is essential to monitor as the patient goes through their course of recovery and addressing any issues with, say, sleep and stress appropriately. Engaging in physical therapy early for education and graded activity. Coordinating return to work with concrete functional restrictions. Using a consistent team messaging to avoid nocebos and reassessing, again, at the latest, 4 to 6 weeks, escalating only if indicated. So with that, I'll open the floor to any questions.
So feel free to either unmute yourself and ask your question. You have one. Especially like that last case you have. Mm-hmm. What strategies do you use or recommend using when educating a patient about this, about your findings? So you find a cluster of red flags. Obviously, that's not enough to diagnose, mm-hmm. but it is enough to, in that case, provide urgent additional examination, MRI, stat MRI, emergency department referral.
Yeah.
What kind of wording would you recommend using?
So I think in that case, we're honest with the patient and making sure that we are not instilling the fear of God in them, but making sure that they're aware that it is an urgent case and that we are finding suspicion that there may be something going on that we would not be able to, I'll say, correctly treat in this setting, and that we are going to send them on for additional imaging or referral to the emergency department for them to perform the appropriate imaging, and that getting this addressed early, and if there are no findings, then we can reconvene and continue our course of action. But getting that patient into the correct hands is essential, and making sure that they're aware of that.
Excellent. And then making sure that they know that we'll follow up with them.
Absolutely. Absolutely.
While we're waiting for additional questions, you mentioned, and thank you very much for sharing the story about your father. Mm-hmm. In that case, what red flags would you have clustered to help make that referral earlier? You mentioned about the night pain, mm-hmm. but that, as you mentioned, that's only one red flag. What other red flags would you have clustered if you knew to ask those questions at that time?
Sure. So at that time, he did not have a history of cancer, so that would rule that out. So that night pain, that unrelenting night pain, is definitely adding to it. So the fact that he was not able to get back to sleep, and after I asked further, he would get up in the middle of the night and lay on the floor because he couldn't get back to sleep in bed, and he found lying on the floor somewhat helpful, but never really got back to sleep. So in addition to that, he didn't really have much of the change in weight. I will say that there may have been an absence of some of the other red flag signs that I would have seen. But the fact that he wasn't responding to conservative treatment is where I lost my, I'll say, way, because I did not follow up in a timely manner. Because essentially, if what we had discussed and prescribed was not working at that 4 to 6 week mark, okay, then additional intervention or evaluation is appropriate.
Excellent. Thank you. And great talk, by the way.
Thanks.
Other questions? Right. Well, thank you very much for this wonderful talk. If anybody has any further questions or follow-up, please reach out directly to Dr. Clemson or to myself. Oh, there is one other question. My apologies. What if a patient only has one prominent red flag, like present history of cancer? Would you still treat and refer, or would you refer the patient first, get further imaging, and then manage based upon the results of the imaging?
So I think that would depend on the evaluation. I think we would go through with an evaluation there. Just having a history of cancer is not inclusive to that cluster of signs for the red flag. So if there is high suspicion and things are not adding up during your evaluation or your examination, then yes, I can see potentially referring and monitoring. But if there is not a correlation between your exam findings and that cluster, I think I would have low suspicion, but continuing to follow and monitor and follow up with that patient appropriately.
Okay. So if I'm understanding you correctly, if you can change that comparable sign, that's a good thing. And if you cannot, that's when you would increase your concern. Correct?
Absolutely. Yeah. The mechanical versus non-mechanical.
I will see you next month. Thank you very much.